Hello, welcome to our event for Black History Month. Tonight, we are excited to have Tour for Diversity, speaking on racial discrimination in healthcare, understanding the impact of diversity in medicine. I would like to introduce tonight's moderator, Dr. Kameron Matthews.
Thank you so much, Dr. Savoy. This is really exciting for us on the tour to join Coppin State in really celebrating this February more than anything, but having what we all think is a pretty important conversation to really think about race and racism even within the healthcare professions and understanding the importance of diversity in medicine. That is something that the tour, as we call ourselves for short, the Tour for Diversity in Medicine, we are really committed to as far as working with students around the country to understand the importance of diversity and why it's actually impactful for our patients. And we'll go into that. This is not just a feel-good argument about seeing more of us that look like us in medicine or dentistry or pharmacy, any of the above, but it's really about how we can help our patients first and foremost. So we hope you'll come away with that sense as well, and a little bit more insight from our own personal experiences. Each of us are actually practicing physicians and have had what you'll hear are some interesting interactions and that really have, I think, framed the way we practice medicine, the way we approach our patients, and really actually excites us every day to have this type of conversation, to be honest. But with that, let me just briefly, didn't even do this, I just started talking. Let me briefly introduce myself. My name's Dr. Kameron Matthews. Again, I am one of the founders and the director of the Tour for Diversity in Medicine. We are a nonprofit organization focused on increasing underrepresented minorities in medicine, pharmacy, and dentistry. We do focus on multiple professions. I'm going to then ask my colleagues to introduce themselves as well. Dr. Winters.
Hi, everyone. My name is Dr. Tyree Winters. I am a pediatrician by training. I also do academic medicine, so I oversee the pediatric medical education for the Department of Pediatrics at Goriop Children's Hospital in Morristown, New Jersey, roughly about 16 miles away from Times Square. Dr. Haamid?
Hi, I am Dr. Ameera Haamid, and I am an emergency medicine physician here in Chicago, Illinois. I am actually here representing the University of Chicago today. I just switched jobs. I'm the current assistant EMS medical director of the Chicago South EMS system. I have a fellowship in pre-hospital care, and it's great to be with everybody today.
And Dr. Brown, I'm so glad you were able to join us. You want to introduce yourself?
Sure, no problem. Dr. Italo Brown, also emergency physician, assistant professor at Stanford, and also social justice and health equity curriculum lead at the School of Medicine. It's good to be with you all today.
And Dr. Henry, for rounding it out, you want to introduce yourself?
Hey, good evening, everybody. Sorry I'm a little late. I just finished with my last patient. My name is Brandon Henry. I do sports medicine. I'm the Chief Athletics Medical Officer at California Baptist University in Riverside, California, graduate of Howard University, HU. And it's a pleasure to be here with you all. And yeah.
Perfect. Well, you can see, honestly, the dedication that we have to this type of conversation where Dr. Henry, again, is literally finishing with the patient. But we actually find this sort of dialogue, again, not to just be stimulating for ourselves, but for students to understand that we are living this every day, that we are practicing medicine and hoping to make a difference in our patients' lives and honestly in our families' lives, in our communities' lives on a regular basis. And so we're really happy that we have such amazing docs like you see in front of us that are actively engaged and hopefully making a difference in every patient's life that they touch. So with that, I'm going to start sharing. We're just going to give a little bit of an introduction to the topic that we're discussing tonight, and then we're going to jump into some personal stories. I'm going to moderate and really ask our four panelists here to share some insights and hopefully provide a little bit of hope about the direction that we are going in healthcare. But with that, I'm going to turn it over to my colleague, Dr. Winters, who will take us through the first couple of slides.
All right, so we are just going to briefly go over a few different slides that we'll talk a little bit more about racism as a whole, and then how racism is affecting medicine, not only within this country, but also different disease processes, et cetera. So all of us are going to take roughly about maybe 5 minutes at the most to go through all of our slides and then be able to get to your questions and answers, which we definitely want to get to. So first slide, we're just going to break down racism. A lot of us may be familiar with this topic. However, just really being able to have a good understanding of the definition here, which is racism is a system of structuring opportunity and assigning value based on a social interpretation of how one looks, or what we call race. So what we do know is that this system can disadvantageously impact certain communities and also certain groups of people, versus it can be a more positive for some, negative for others. But however, we know that this construct, the social construct, is just a continued waste on human resources. When we go to the next slide, we'll talk a little bit about how racism itself and systemic racism has played into a part. When we really think about the construct of this country, even as far back as 1619, which I know has been a hot buzz topic lately for a couple of our states down south. However, when we really start to think about populations such as African Americans, Latino Americans, and American Indian populations, Native Americans, we know that based off of systemic and institutional systems that have been in place, this has been a system that has unfortunately impacted us in such a poor way, whether it has been higher rates of unemployment, whether it has been significantly lower household net incomes, that can affect the way that our communities are receiving resources, whether those are resources within education, within healthcare that's being provided, transportation, all factors that can then lead to us being able, within our predominant communities, being impacted by the way that we're unable to be able to receive care, be able to receive services that are available to others. Next slide. And the fact that you are seeing not only services that are being affected by racism, but also racism can affect health. It can affect health based off of the fact that there are certain different factors, whether it's something that's called epigenetics, where literally the stress that is associated with different systems that are in place that can negatively impact the way that we are being able to carry out certain disease processes, meaning you can see even in certain populations, whether that is in infant mortality, Black and brown mothers having higher rates of infant mortality based off of the fact of the stress that has been placed upon them. And this is stress that can then be carried out throughout someone's life. And it can be passed along from generation to generation. And this has been proven actually through research that have shown us that this is the case. Not only that, but it can also negatively impact the way that we even carry out interpersonal relationships, not only within ourselves, but also with our healthcare providers, with our teachers, with our, whether it's businesses, et cetera. Next slide. All right, and then social determinants of health, when we really try to think about what are all of the aspects of health that can be affected by this can then lead to economic instability, neighborhood and physical environment that can be affected by education, food, community, and social context, as well as healthcare systems, all can be affected based off of all of these different institutions that can be affected by racism. And so this can lead to poor outcomes and mortality, morbidity. So not only thinking about death, but thinking about whether it is the percentage or incidence in different health illnesses that we have in place, life expectancy, all of these things that when we think about our education and we think about the education of physicians as well as other healthcare providers, we tend not to get this education as widely as we would hope to, especially within the systems. And this is why we started having talks such as this, even going down to individuals that are in pre-med as well as even in high school, to be able to start to educate more and more of our future healthcare leaders on these topics. And next slide.
So thank you, Dr. Winters. So Dr. Winters was talking a little bit about some of the language we're going to be using today and some definitions. So he touched on social determinants of health, which are those non-medical drivers of our health outcomes. So there are things in our lives that aren't medical that drive whether or not we're going to live longer, live a shorter lifespan, have different disease burden as we grow and live. So these are secondary to the conditions that we're born in, the conditions that we live in, the conditions that we work in. So it's not our personal choices of whether or not, right, we're smoking, we're drinking, or whether or not we decide not to take the medication that the doctor gave us. It's really about what we have at our disposal to keep us healthy. So it's our neighborhoods, whether or not our neighborhoods are safe, right? Will determine whether or not we're more likely to die from gun violence, whether or not our neighborhoods have food or healthy food stores in a nearby vicinity. That determines whether or not we're going to be able to eat healthy, right? Underfunded school systems will definitely have an impact on our education or the quality of the education that we're getting, and our employment or our finances. That impacts whether or not we're able to not only afford health insurance, but also afford the medications from the pharmacy. And then lastly, stress, discrimination, racism, all of those things have a large role in our health outcomes. As far as health disparities, that's the second definition that we'll talk about today. So health disparities refers to the discrepancies in health outcomes between different groups of people. More specifically, these are preventable differences in the burden of disease or injury amongst groups of people. So just by saying that, I think some of the most common things that come to mind are, like Dr. Winters said, like infant mortality, right? Black babies are dying at higher rates than white babies. Also heart disease, stroke. We have higher rates of death in our community, other than when we're comparing our community to the white community. And then the most recent health disparity that's made the news that I think Dr. Brown is going to talk about a bit is COVID-19, right? Black individuals, Latinx, and also Native American, Alaska Native groups are dying at higher rates and being affected at higher rates. So those are health disparities. Health equity, so that is the expectation that every person, regardless of their group or classification, it's the expectation that they can reach optimal health or optimal health outcomes, regardless of their social circumstance. In order to understand health equity, you have to really understand the definition of equality versus equity. So equality is basically giving everybody the same thing in order to succeed, right? And then equity is giving people what they actually need to succeed. So if you think about that, if a person speaks Spanish, right, you would never give them instructions in English. They couldn't understand it. What they need are instructions in Spanish. If a person is wheelchair bound, you would never have them go up steps, right, in a wheelchair, right? They need a ramp. So that's what they need. So it's meeting the patients where they are. And secondary to racism, discrimination, that started way before you and I were, here. There are different groups of people that are highly disadvantaged, and their neighborhoods have been disinvested in. So we need to meet those patients where they are in order for them to have optimal health outcomes. You can go to the next slide. So for a long time, people have said that they don't see color, right? Or they're not racist, but it's no longer okay just to not be racist. So you really have to be anti-racist and have an anti-racist mentality as you approach health equity in order to achieve optimal health outcomes for all people. And in order to do that, you have to address race, right? It's no longer okay to not address it. And when you're addressing race, you have to look at the historical context because that's needed to understand current literature and treatments as it relates to the exclusion or exploitation of BIPOC populations. And you also have to address race to understand racialized health policies that cause minoritized populations to be less healthy. And lastly, you need to address race to understand systems and thought processes within healthcare that perpetuate that racism. And we all have, we all pledged allegiance to the flag and did our Hippocratic oath when we started medical school. And we basically said in all of that we were going to do right by all the patients. In order to do that, we really have to be anti-racist within our practice to dismantle some of those systems that disenfranchise our patients. Next slide. So what does anti-racism look like in medicine? So there is no cookbook to anti-racism, but some of the big thought bubbles are to reform curriculum. So reform it, take a look at it and see where implicit bias lies and take that bias out or address where that bias is. That way you can have health equity or equitable outcomes for your patients or more equitable outcomes for your patient. Also look at where health disparities exist. And if you're having a topic or discussing something, ask those questions and have that written into the curriculum to discuss, the differences in health outcomes amongst populations and the root causes behind that. That way, the physicians and the pharmacists and all of the different specialties of medicine that we're training can address those and make the world a better place. I wasn't going to say that because that sounded cheesy, but make the world a better place. Also with their training, we have to introduce implicit bias training into medicine, cultural competency, and addressing of health disparities. We can also evaluate our own practices and behaviors and actions through a lens of anti-racism. And then lastly, diversification. Diversification of our workforce will lead to diversification of interest, conversation, and people that generally have a different outlook and honestly a different skill set in addressing those health disparities for our marginalized patients. Go to the next slide.
So we mentioned for a second that the real life case study for health inequity revealed itself over the last 2 years. We've undergone something significant as a community, as a global community. And in the beginning of the pandemic, there were concerns that there may be evidence of health inequity based upon pre-existing conditions, but it wasn't just that, right? There was more to it. We spoke about health disparities. So you have the language around social determinants or social drivers of health and health disparities. Well, COVID-19 was that particular instance where all of these underlying unaddressed chronic health disparities or issues where social drivers of health have manifested essentially pushed the outcomes in a way that we saw disproportionate health outcomes for certain groups of people. And I think that this is a key differentiating factor from other medical issues that we've seen, where usually this has been insidious, something that's slow and progressing very underneath the radar. Well, this occurred right in front of our faces and we were forced to pay close attention. Next slide, please. The stories that were told by the data, by the numbers, were a lot different if you were a person who came from certain communities, if you had a certain racial ethnic background. And what we know is that Black and Brown communities are disproportionately affected by COVID-19, not just from the stance of mortality rates, but also from the stance of hospitalization. And this trend is something that mirrors or parallels what we've already seen in multiple health conditions. I think the more important facet now is, even though we are 2 years into a pandemic, we still see somewhat of a similar disparity, not just in the health outcomes, but also in vaccination rates, less likely to be vaccinated, less likely to have access to therapeutics. It follows this same trend where Black and Brown communities seem to be marginalized more so than white counterparts. Next slide, please. And so when we start to look at the interplay or the factors, those core features that lead to or contribute to why this exists, it boils down to, as we've said in that language, knowing when that social drivers of health, those things like access, insurance, income, education level, transportation, and housing have a differential effect. And it's because of the way that our communities are established in the investment or disinvestment, as stated earlier, in those communities. And then there's systemic and structural racism, which is a component that often is not discussed blatantly. It's often something that is alluded to, and how systemic and structural racism seems to not just amplify poor health outcomes, but be a driver and a contributor to those things as well. Examples such as when you look at who is your house staff inside of a hospital, who tends to have the majority of essential workforce jobs, who happens to be more likely to live in housing where multiple families or multiple members of a family are in the same space and unable to quarantine effectively. And even looking at resources in the community, the likelihood of having just a safety net hospital and not additional resources, all of these things contributed to the amplified risk and also the disproportionate outcomes that we've seen in COVID-19. I'm going to pass to the next person.
All right. Can you guys hear me? All right. So my friends and colleagues have spoken to you guys about social determinants. We've discussed health inequities, and we've discussed the importance of language. These last two slides that we have here really kind of sum it up, right? The whole idea of why we need you is really to enforce this idea of we actually need you, right? Like we're not just saying this just as a cliche, right? We're not saying this just so that we can convince you to maybe do something that you don't necessarily want to, or, we're not trying to follow a trend. We're actually showing you numbers that actually show you that we actually need you guys to do this, right? To do what you set out to do what those around you have encouraged you to do. Again, numbers are facts, right? Like you see these numbers. And I think a lot of times we get caught up in the pure emotion of things at times, and we try to ignore facts. And there's a lot of people around us in different communities and such that will ignore the facts, and they will come to you and speak to you on their thoughts, right? And not necessarily things that are actually factual, right? You're looking at numbers that are actually factual, right? You're looking at a number that shows you, right, that says the percentage of all active physicians, right, by base and ethnicity. You're looking at a number that says we as African Americans make up 5% of that workforce, right? If you were to put that on a small scale, what 5% is? What, 1 out of every 10? No, that's 10%. We're talking about half. My bad. I'm sorry. So again, right now we're not even a whole person in a sense when you look at numbers to a certain degree, and that brings on a whole different conversation that we don't have enough time for today. But again, what I'm trying to drive home to you is that we need you, and we want you, right? We are all here for this fight. We are all in together with this fight, but we need you guys to join us in this fight if we do want equality to happen at some point. Next slide. Again, we're looking at numbers, and now we're looking at pharmacists and dentists. Me growing up, I never had a dentist. Now, had I had a dentist, maybe I'd feel differently about wanting to go to the dentist, but then maybe that would have given me thoughts of maybe something that I could do in life. And maybe it would have encouraged me to attack things that are out there that are disproportionate in our communities when it comes to dentistry, right? But again, you're looking at a number that says 3.7%, right? Again, we're not there. But if you that are joining us on this call, and if you have that itch, that burning desire, you have that fire in your belly that says, you know what, dentistry is something that I'm passionate about, and I want to do that, then you look at this number and you say, you know what, I am needed, right? And that when you become that dentist, become that pharmacist, become that physician, podiatrist, whatever, then you step into doing these roles that we're doing here. And then now we can continue to get this snowball effect of making change actually happen. But guess what? That can't happen unless you make it up in your mind that says, you know what, this is something that I want to do, and that this is something I can do, and that I'm going to do. And we are here, right, as faces on this screen, and voices that you hear, and images in our community that says that whatever it is that you want to do, you can do. And you will, as long as you put whatever work you got to. And again, just understand there's a passion for it. And I could keep going on about this, but I want us to get to the story of it. But I want you to understand that it's a sincere thing of, we need you.
Love it. Love it. Thank you so much. I consider these guys my friends, my colleagues, but more important, my family. And I love how we're able to really kind of quickly put some summary behind what I think is probably really at the base of all of our careers and why we went into medicine. So I absolutely love Dr. Henry's kind of final message there that, we need you in order to really address these health inequities that Dr. Haamid discussed. So now, if you guys don't mind, I'm going to really moderate a discussion amongst the family here to really get a sense and to share some stories that we have from our different experiences, because I think they frame our practice of medicine in every way. I said that at the beginning, but I think they frame how we are clinicians, how we are physicians, and I think they give some real insight as to why diversity is so important. So I'm actually going to bounce it right back to you, Dr. Henry. I'm going to go a little bit out of order, but that's okay. You're used to it. I would love to hear, I think particularly, don't get me wrong, or tell me if I'm wrong. Do you have any particular stories, particularly about discrimination as you are coming through your training, and how potentially as a student or as a resident, it really framed your experience?
Yeah, there was a very strong example of it that I dealt with my intern year. So I'll give a kind of a frame of it, is that I left Howard and came to Loma Linda University, which is it was a pediatric program here in Loma Linda, California, which is San Bernardino County. Now, mind you, right, I was leaving an HBCU and coming to a very much PWI institution, right? I left Howard with a sense of passion, a sense of strength, a sense of courage, a sense of knowing who I am and what I brought to the table. And it's, they would always tell us, this is not the real world, so just know that, right? Like, you're loved and protected here, and you're taken care of here, and we build you up and we strengthen you so that when you do leave this home here and you get out into the real world, you're going to have to use all of this, because it's going to come at you. And I think a lot of times I didn't really pay attention, because I was so happy and good with where I was, and I just said, okay, I'll be fine. Anyways, I get on to intern year, and our program had about 100 residents. We had about 30 something pediatric residents in every single class. My class had 3 African Americans out of the 33 residents that were there. And one of my days off, because again, I was always taught to go above and beyond, right? We have to be better. We have to put in the extra work. So on my off days, I would come in so I could work on notes, maybe do some studying, and honestly, just get the lay of the land, because it was a new place for me. I came in one day with just some regular Levi's on, plain regular t-shirt, and I had an Old Navy zipper tee and my LA hat, right? I was happy to be home, so I had my Dodgers hat, go Dodgers. And I walk in, and the first thing somebody said to me was, "Oh, hey, I didn't recognize you. You have on your thug clothes." And I was, it's one of those where, where you almost like when you get hit in the nose and you're kind of shocked because you actually got hit in the nose and you're kind of like, what just happened? And that's kind of what happened to me. I was actually very shocked, and I didn't really know how to respond. But what I did was I internalized it, and it hurt me so much, because again, I didn't have anybody I could talk to. I didn't have anybody that could relate to what I was feeling. I'm now a physician. I have MD behind my name, and now I'm being called a thug simply by wearing regular clothes. And again, it caused me to really isolate myself. And I ended up really going into a pretty deep depression in my intern year, whereas for about 8 or 9 months, I struggled big time. And Dr. Matthews can tell you, and Dr. Winters, I didn't know what to do. And we even had a stop out here that we did in a part of California. And so much of my emotion of what I had experienced bubbled over because of our experience that we had at a restaurant. And I had to physically leave the restaurant, went outside and just bawled. I cried for a good 10 or 15 minutes or so because I was so angry that I didn't know what to do. And so with having my family here and with still having my family back at Howard, I was able to talk, have real conversations and understand that I'm not who they say I am. I'm not who they think I am. And honestly, I'm not going to waste my breath. And this is how I took it. I wasn't going to waste my breath and my time in trying to explain to them who I am. What I'm going to do is I'm going to show up to work early. I'm going to continue to leave late. And I'm going to show them by my work that I am who I am and that I deserve to be here. And there's nothing that you can say or do that will run me off. You almost had me. I was ready. But I'm stronger than that. And I was always taught that I was built Howard strong and I was made for this. So, yeah.
Dr. Henry, I remember that time. I hate that you went through it, but I think you are ever stronger because of it. So thank you. Thank you for sharing. Dr. Haamid, I wanted to jump to you next because I think you also had a rather personal story of yourself as a patient that you don't mind sharing about kind of your experiences in this space. Do you mind telling a little bit?
Oh yeah, no problem. Yeah, so as we talk about health disparities, it's not just disparities in health outcomes. There are disparities in how physicians treat patients, right? So there's a lot of data that shows that if you are a Black or Latinx and you go to the emergency room and you have the same fracture as someone that is white, that person that is white is going to get pain medication more frequently than you will. And that goes back to just historic perceptions of pain and just in general racism and bias. So I was actually in labor. So I was in labor. I got induced for my daughter. I was about a week past dates and I went in to be induced and it turned out to, that those Braxton Hicks were actually real contractions. Either way, they started me on some medication to give me some stronger contractions. And needless to say, about maybe 2 hours into it, I was having really strong labor pain. And instead of being offered pain medication, I was told that I shouldn't have pain to the degree that I have pain. And this is at the point where I'm grabbing onto the bed rail, shaking, and they immediately wanted to give me an epidural. So knowing what I know as a physician, the jury is kind of still out as to whether or not getting an epidural too early will actually arrest your labor and cause you to have a C-section. And that was the last thing I wanted. I did not want a C-section at all. So I had to pay for this course. I don't know, that's a whole another story, but there's a course before you give birth. They don't even, anyway, you had to do a little plan. So I had to come up with this plan. And I said, when I was so many centimeters that I would go ahead and get the epidural. But before that, I would get IV pain medication. I didn't know what kind of pain medication they were offering. I just knew that it was pain medication. Anyway, the medication that they were offering was Dilaudid. And that medication is highly sought after with people who do abuse drugs. They may come into the ER or other spaces and ask for that particular pain medication. And when it was time for me to get a dose of pain medication, they said, ooh, we're going to have to call the doctor about that. Ooh, we're going to have to wait for her to get up here. We just paged her. And ooh, I mean, where is your pain at? All of these questions. And I don't know about you guys, I mean, all the ladies on here who have been in labor, oh my goodness. But for all the people who haven't been in labor, I think you've already heard how painful it is, right? You have some thoughts about how painful it is, but instead of me being offered that pain medication, I was questioned and interrogated, and I had to prove that I was in that degree of pain to get that medication, which is unfair. And then unbeknownst to me, 2 weeks later, a friend of mine who is white, her sister gave birth in the same exact hospital. I'm not sure if she had the same nursing staff or anything like that, but they were basically offering her pain medication, even though she wasn't even in pain. So she had to keep declining. She said that she serially declined pain medication over and over. Meanwhile, I, the Black patient, had to keep begging for someone to take me seriously. And it's not just me, right? Like, this happens all the time. There's data out there that proves that it happens, and it's unfortunate. And then after I had my daughter, I was actually in the hospital with her. She wasn't taking oral food, and we got admitted for an observation for a night. And the physician came in the next morning, and I had been up with her for 30 hours straight. I was up 30 hours straight, like hovering like a helicopter mom, like, is she breathing? Because I'm freaked out and she's only 4 weeks old. He came in the room, and you can tell his entire demeanor. It was as if, he treated me like I was stupid or uneducated. He treated me like he didn't share what was going on with me. It was as if he felt that I wouldn't, I'm not sophisticated enough to understand. And that is something that's passed around in the medical field. I have had a physician call me because I work in the ER. I've had a physician send their patient to the ER, and he wanted me to do this really extensive workup. And I said, well, actually, I got an interpreter. Okay, step one, I got an interpreter. And she actually just says that she's constipated. This is not what you think it is. It's not an emergency with her spine. I'm going to do, this and maybe, and then he really run depressed. I said, well, let me talk to her about it. And if she wants to do it, I'll go ahead and do it. He said, don't talk to her about it. And I said, why not? Shared decisions making is encouraged in the healthcare field. That's when you talk to your patient about what's going on, so that they understand. You tell them what you're concerned about, and, lay out the different options. You guys choose a care plan. That way the patient is, involved with their care. And I offered to do that with her, and he said, don't do that. And I said, why not? And he was like, because she's not sophisticated enough. And I said, what makes her not sophisticated? And I, very directly told this senior physician in the hospital, I said, is your mother sophisticated enough? Is your sister sophisticated enough? Is it just because she speaks Spanish that she's not sophisticated enough? I said, their entire family is in the room. They all sound sophisticated enough, but that was clearly him using bias, right, in his decision-making and his healthcare for this patient. And that happens day in and day out, which is why there is strength in diversity, and diversity is honestly a gift in the medical field for our patients that are diverse. That way we can care for them, in a way that we feel that they should be cared for.
Ameera, same with Brandon. I just really appreciate that you're willing to share that story. It is unfortunately not unique, and that is the absolutely intolerable part of this conversation, that we have so many from Black and Brown communities that have the same experience. And again, this is why diversity is so critical, because you were that advocate in that patient's life, right, in the emergency room, and that's exactly where we need to find the solution. We are not the only solution, but we are one solution to fixing these issues, right? Dr. Brown, I'd love to hear more about your experiences in the emergency room as well. I think from a probably trauma and violence standpoint, maybe also pain management as well too. You have had some pretty intolerable experiences as well too. Maybe not personally, but maybe more so with your patients or others' patients.
I think that one of the things that we don't discuss is that if you're a young Black male, you come into the emergency department, there's an embedded stigma. It's always not, are you here for care, but why are you here? And I think that there are so many different other nonverbal things that contribute to the treatment that's received by young Black men, especially in the setting of trauma. Some of the stories that come to mind are the way that officers can speak to the providers to essentially contextualize what the reason that person is there for. So having an officer escort a patient who may be a young Black male and saying like, oh man, I caught him doing this, he's a gangbanger. And then all of a sudden, the perception of that patient is changed, and it can somehow represent itself, not just in worse health outcomes, but also can be documented in the chart like that, giving additional information with negative descriptors. And so that person essentially creates, or whoever wrote that creates a track record for that person. And it follows them for multiple years of getting care, being told that they were aggressive or being told that they were a little bit defiant just because they asked more questions. Or because they said, I'm not going to do that, and exercised actual rights that they have as patients. So, these are common experiences. And I would also add that I tend to see a lot around pain control because in emergency department, most people are coming there on, their absolute worst day and are in need of some type of service. There are some heartbreaking stories I've heard around chest pain where, there's one story out of, I want to say out of St. Peter's, Missouri, this guy named David Bell, I believe. He went to he went to the emergency department 3 times. Each time he went there with the same story of chest pain. They did a very simple workup and discharged him. The 3rd time he was discharged and died in a parking lot. He died in the parking lot of a massive heart attack, and it was just slow progressive signs of this. And it's not an uncommon thing. There's a statistic that says that Black people are far less likely to have cardiac activation than other cultures. I mean, specifically than the white counterparts. So you can lean on the data, but you can also just lean on sitting in an emergency department and seeing look at hallway beds versus rooms. Where are the patients of color being placed? How long is their disposition? And how long do they wait for pain meds or anti-nausea medications or just before getting discharged? How long do they wait for substance use counseling? All of these metrics are things that we follow, and it tends to tell a very eerily similar story, which is if you are Black or brown, you may not get the best care, and it's not going to be due to just, a particular clinical condition. Is probably going to be related to an implicit bias that has been masked.
Thank you, Dr. Brown. It's alarming that these institutions that we're supposed to have trust in, right? Unfortunately, for extremely valid and I would say historical reasons, right? That we need to question it and that you have seen it firsthand. Dr. Winters, I'm going to flip the switch. I usually ask you a story as well too. Dr. Winters, you're a pediatrician, and I know there's a lot in that kind of we call it the outpatient setting away from the hospital. I know there's a lot that you've seen, but I actually want to flip it because I feel like we're getting a little negative, right? I mean, we are all clearly in healthcare, right? And we all love our jobs, and we all recognize the need for more of us. Like Dr. Henry said, there's only 5% of us right now, Black or African-American. Dr. Winters, I'm wondering kind of from your job, especially in academia, meaning you are training the future physicians. What sort of hope do you see in these physician trainees that are coming through training now? Do they have a better perspective? Are you seeing and how's your mentoring? How are you coaching them? Do you have kind of hope for this next stage of where we can go and how we're diversifying healthcare?
So I do have hope. I do also want to tell my story.
I know you but I want to stay positive.
Well, you know what? I mean, in telling my story, it's also a way of staying positive as well, because of the fact that one of the reasons, and it leads to a question that was being asked in the Q&A, and I know you're probably getting to it by Dr. Bolden, which was, how do we guard against or deal with secondary trauma on top of the systemic racism? And so one of the reasons why I literally wanted to go into academic medicine was because of the trauma that I wound up having in my training. And needless to say, there are so many different stories and incidences, whether it's macro or microaggressions. But I remember being in residency and being the only Black male out of 135 residents at Nationwide Children's Hospital And when I went through that, I just remember being compared to a couch. The reason why is because we wound up having a new couch in our resident lounge, which we used to affectionately call Big Blue, which was a big blue leather sectional couch. When my second year residency, it was renovated, that area was renovated, it wound up being a big black leather sectional couch. And so everybody said, well, we call it Big Blue all the time. What are we going to call this new couch? And having some of my co-residents say, well, let's call it Ty because it's big and it's black. For those who don't know, can't see me in person, I'm 6'6". So that was something that was completely just, as Dr. Henry and all of the other docs on this call can tell you, it's earth-shattering. But I realized too, I'm just one of those type of people that I constantly feel as if my hand is on the fire of life, I gotta take it off. And I gotta make sure that how do I take this off by reaching further into the problem, being able to change that up. So by becoming a program director, residency program director, and by becoming the division chief over medical education for my Department of Pediatrics, it allowed for me to be able to institute not only some of the tools that we all know and utilize, whether that is visiting minority clerkships, to be able to have students come in and rotate that may or may not have been seen as ideal candidates, to show that numbers, or even whether the numbers are fine and everything is fine, giving folks a chance to be able to prove and show themselves to not only be as adequate, but a lot of times better than their colleagues, and being able to not only perform clinically, but also to be able to operate within our institution, which sees a lot of individuals that are diverse, to be able to have that connection, that one-on-one that a lot of their colleagues may not be able to have. But with that being said, the thing that I do have also hope in is the fact that by being in this role, it also affords me the opportunity to, in essence, require that our faculty go through development through the ACGME, so the Accrediting Council of Graduate Medical Education. It says that part of my role is that I have to educate the faculty to be able to be competent, to be able to teach my learners. So because of that, we were just having this conversation prior to being on a call, all of my faculty now, all 100 plus, will have to go through diversity, equity, and inclusion training that I put on board. So tomorrow I'm giving a lecture on how to build an inclusive team. That doesn't mean just building a team for our residents or making sure that the medical school is accepting medical students that are diverse. That's mean looking inward, looking at our faculty, seeing the fact that there's not a whole heck of a lot of us that look like me. And how are we going to change that? And don't tell me it's going to be a quota, or don't tell me that we're just going to put someone else into a position of leadership, because we know through data that doesn't work. That's how a lot of us are being able to respond to the secondary trauma, by putting it in action, taking our pain and being able to do things such as this to be able to ensure that others behind us don't have to go through that pain. Now, I can't lie to you and say that we don't have times where things will not always work out. I've had the privilege of being able to be a program director for another Black male pediatric resident who unfortunately had to suffer so much racism in my department that it hurt me to the core. I mean, it hurt me to the core because I thought to myself, as I failed him. I failed someone who I purposely walked into this role, into this position, to be able to protect him from. And that shows me that, one, it's a lot more work that we have to do to be able to get to this point. But two, it also allows me to be able to see that before, when I went through these things, there wasn't somebody there who was able to guide me and coach me through this. And it wasn't someone there who could also make sure that this would never happen again by putting things in place. So, it's just the same way with anyone who has kids, right? kids are going to have to go through things that we wish that we can protect them from, and obviously not comparing adults to children or medical students or residents to children, but in a sense, as a educator, and I'm sure for those of you who are on this call who are educators, you tend to look at them as if they are your own, and you want to protect them from certain things. But this is how I go through the aspect of going through secondary trauma.
I love that. I love that. I want to extend Dr. Bolden's question to any of our other panelists. How are you guarding against or dealing with the trauma that you see, that you experience? Do you have any other kind of insights that we can share?
Yeah, I mean, I would say that you have to practice radical self-care too, right? Like there is something revolutionary about rest. There's something revolutionary about pouring into yourself and making sure that you identify community and find those safe spaces. Sometimes that community is going to be a proxy, or it may be somewhere you have to go that's beyond just the walls of your institution, but it has to be a place that you can unpack those I would say the additional gravity of the work that you do, because it's not that it's always so heavy. It's just sometimes you need a second to make sense out of it. The other thing I will say is the work of it is something that will always have more to do. So taking a second and realizing like this can be done at a certain pace. It doesn't have to be breakneck. You don't have to go from 0 to 1,000. And health equity and anti-racism are not light switches that you can walk into a room and just flick on and all of a sudden it's there. So just being kind and gentle with yourself in the process, reminding your peers that they're loved and they're not alone. And then for yourself, making sure that you factor in and be intentional about building a space conducive to your mental wellness while you do this crusade is important for me.
And sorry, I wanted to piggyback real quick off of something Dr. Brown said. And I think that when you talk about building that safe space, I think one thing that COVID really did, a positive thing that came from COVID was this right here, right? The Zooms. There was a lot of people who, again, if you look at our organization as the tour, we are spread out all over this country. But what it allowed for us all to do, and even our own individual networks, was that we could have Zoom calls, right, with our friends, so we could see each other. We could have these conversations, and it's different when we're doing this and seeing each other because there's emotion that we can see and feel through this avenue rather than just a text message or phone call. So, I think that was definitely something that came great out of COVID. And then real quick, I want to say with the hope piece that you spoke of, Dr. Matthews, is that I think being a part of this organization has given me hope, and I think it's given us all hope because we've been able to see the growth of things in an amazing way, right? Ever since we've started this organization, and and every single year, right, we get more and more mentees, or just more and more people that we are able to maybe have a positive impact on their lives. And for our audience, just so you guys know, we have this thing called W's where we share with each other positive things that have happened with those that we may mentor, those that maybe we had a conversation with, maybe those that we had an email conversation with or text or whatever. But we've seen the number of young people who are going into these fields, right? We've been able to actually physically see that. And I think it's a beautiful thing because it shows that if we get out there and put in the work, there's going to be a return on that investment. But you just have to be willing to put in that work. So I just wanted to touch on that part of the hope, because it's been a beautiful ride to see over these past 10 years, just to see how things have changed in some kind of way.
Yeah. Just so our audience understands, the tour, we've been traveling the country and now been virtual since 2012. So when we were young and green little doctors, and here we are now some 10 years later, and we love going around and talking really to students across the country. We've been to 27 states when we were in person, and now that we're virtual, we reach as many students as possible. And so it's our pleasure to do this sort of programming like we're doing tonight. I have one last question, guys. It's totally flipping kind of the focus, but I think it's a completely legitimate one when we're talking about diversity of the workforce, right? And we're talking about our fields that can be quite lucrative, yes, but have financial barriers upon entry, right? It is not cheap to enter these fields. It is not cheap to pay for our degrees. Do we think that student loans, lack of financial aid, anything really that is kind of financially a barrier, do we think that's contributing to the shortage of healthcare practitioners?
You know, not only do I think that it's, I'm sorry, I'll jump in on this one. Not only do I think that it is a barrier, but for medicine, I think in general, for all higher education, right? I mean, one of the things that I am noticing, especially being a practicing pediatrician, one of the things that I can say, and Dr. Henry also is a pediatrician by training as well, prior to sports medicine, we typically, when we do our well child visits, we usually, at least I always ask, like, okay, so what's your plans? What do you want to do with your life? Blah, 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 blah. And it's astounding how many kids now are starting to say, oh, I want to go into, to go to become a mechanic. I want to go to trade school. I want to go to trade school to become an electrician. I want to go into the military. I want to do this. I want to do that. And, you know, before it used to be, and I don't know, I grew up in the old school kind of way where, you know, I grew up in Dr. Italo can tell you as well, being a Detroiter, his parents were Detroiters rather. You know, it was no higher than being a doctor, a lawyer, engineer, or being a pastor for my family. And when I tell you, if you didn't want to go to college in that family who third and fourth generation went to college, it was like, oh, okay, well, you can figure out what you want to do with your life after you go to college. So to have that conversation of like, you don't necessarily have to go to college right away. Sometimes it takes me aback that I'm like, yeah, that's fine. Do what you pursue what you want to pursue. However, I think that being able to find ways to make sure that it's understandable, it's great. Applaud all of the folks that get a chance to go to college, to go to these wonderful colleges, but also you have to think about the aspect of it in terms of financial, whether that's spending the first 2 years in community college or really making sure that we're applying for all of the grants and scholarships that you can get, because it's real and we pay a lot. And fortunately, me and Dr. Matthews were able to get repayment back through the federal government to pay back our student loans, or a good portion of it. But it's a lot. And I can't lie to you and say that I'm mad at folks for starting to think about this earlier on compared to being out there and then thinking about it later.
But you know, and I think the thing that we want students, future healthcare professionals to understand is that there is a path to get support. And actually, we just had an amazing interview. It's on our Instagram page. We did an IG Live interview with Jasmine Chigbu, who is a fourth-year medical student down at Duke in North Carolina, who literally had not only amassed hundreds of thousands of dollars in scholarships just by piecing together different programs and applying, but has since started a company where she is starting to put all those scholarships on a database that students can search. I mean, this girl is brilliant. This woman is brilliant and is trying to share that information. We're actually going to have a financial literacy workshop probably later in March about this. So we want people to understand that there's a way to get through this. There is a way to think about your loans, to think about scholarships, to think about what Dr. Winters just described, loan repayment programs. So yes, you take out the loans, but how you practice medicine later in your career, they actually pay you more money to pay off those loans. So you're not saddled with them over time. There's also plenty of opportunity and scholarship through different military services. And we've had strong partnership with the US Army on the tour. The Medical Recruiting Brigade actually is a great partner of ours. So there's a lot of opportunity out there. What we want students to recognize is that finances are important, but they shouldn't be a barrier, and that there are ways to get over those barriers. All right. With that, Dr. Savoy, we're coming up to the 8 o'clock hour. And unless we have any other last minute questions that the audience wants to drop in, we will say thank you. And thank you for inviting us to have what we think is a really important conversation. And I'll hand it back to you.
Hi, thank you so much. Let me see if I can show my good face here.
Oh, we got you.
Oh, good. Thank you. Thank you for everyone. Did anybody have any last minute questions that they want to ask our panelists? You can raise your hand, I believe, or you can type it in the Q&A. All right. If not, thank you for answering my question about possibly, is there apprehension due to student loans? So thank you. All right, I think we have one question.
A great question. How can physicians join you? Yeah, we are a small family, but a growing family. There's about 49 of us scattered around the country. We actually have an application on our website that I will quickly drop into the chat, where you can learn a little bit more about our organization and apply to be a mentor. We really do try to present what we describe as an awfully diversified face to the students that we reach. We want specialties, we want different fields, we need people from different geographies, different backgrounds and upbringing and everything. So we definitely invite any professionals of interest to apply. Looks like we got really last minute questions. I don't know, Dr. Savoy, and I don't want to hold my panelists. I know we've all had long days and some of us are still in the middle of their day. Dr. Henry, I'm happy to stay on and answer a couple of questions, but if any of my family needs to drop, please feel free.
Okay. Let's answer these last two really quickly, and then that'll be it. Thank you.
All right, great. Was it more challenging going through medical school or coming out and dealing with patients? That's an interesting one. Actually, I don't think we've discussed it. Which was worse, going through school or dealing with the difficulty of
Patience.
That was there.
Patience.
Yeah.
Patience.
Patience.
Yeah. No, they're difficult. And probably for my pediatricians, I'm a family doc. Sometimes
Patients' parents.
It's their parents. That are even more.
Real quick though, I think that's a I want to dispel that, because I have honestly, and especially now being a parent, I get it on a whole complete different level. I honestly do not think parents were that bad. In all my years that I've done pediatrics, I can probably name on one hand the number of parents that were actually just that bad, that were like evil spawns. But besides that, parents aren't actually bad. What I've learned is that they just care for their babies, and their babies are sick and they want their babies to be okay. So their energy is given off in a different way. But I don't think the parents are that bad, actually.
I was going to say the worst ever is insurance companies. That's the hardest thing to deal with as any physician, I think. Yeah.
All right, here's another great one, and we're going to do this quick because I know we all have great stories behind this, but real quick, a couple of sentences. What made each of you pick healthcare as a career? Great question. I'll start off while everybody's thinking. For me, I absolutely love the thought, even at a very young age. I knew I wanted to actually be a physician at a very young age. I love the thought of being able to help every single person around me. And it, I'm a family doc, so we say cradle to the grave. It doesn't matter the age. It doesn't matter what the issue is. I knew just even kind of seeing doctors around me, they just, someone saw them and they just felt this trust and they felt that they could help them. And I wanted that connection with people. So for me, it was never a question. I always wanted healthcare.
I'll jump in real quick. For me, initially, I wanted to be a doctor because my grandmother was misdiagnosed with pneumonia, and she actually had terminal cancer of the liver, lungs, and pancreas, and I lost her 1 week later after, and she was the woman who raised me. So she made me want to go into medicine, and having been an athlete all my life, playing sports, baseball and football into college, I knew that I wanted to be around sports, so sports medicine was naturally just the best fit for me.
I'll go next. So my dad was actually a medic in the Army. So I just imagined as a kid watching all these movies and seeing him like run towards danger and helping people in need. So that's kind of how I ended up in emergency medicine. And I did just want to shortly say, or just briefly say, I thought that medical school was tough. I love the patients because the patients are so funny. I feel like I have the funniest like thoughts in my head at all times. And I don't know, the ER is a great place. You meet all these people from all these different walks of life. So I really love the patient and doing all the stuff that you read about in the medical books. Like you're finally doing it, right? You're getting fluid out of a knee and look, it looks like straw, you know? So it was amazing. So.
Love it.
I come from a public health background, then went into medicine. And the thing that made me choose it as a career was the ability to advocate really at a high level, getting certain skill sets and tools, not just being able to practice clinically, but being able to be a health communicator for a community, like knowing this stuff in and out and being able to be something that my family didn't have access to, which was a person who was down to earth that could speak the language of the physicians and could actually give insight from a culturally informed perspective. That's why I went into medicine.
All right, brother. You made me want to go like this. I went into pediatrics because I had a phenomenal pediatrician. I was fortunate enough to have a Black woman who was my pediatrician. She literally graduated 50 years almost to the date that I graduated from medical school. She graduated from Howard University, a member of Delta Sigma Theta Sorority Incorporated, and just was a phenomenal woman. And she was my role model. And so that's one of my role models. So that's the reason why I went to go into pediatrics.
Thank you, guys. Thanks for sharing the story. Dr. Savoy, thank you so much for having us.
Thank you. I really appreciate it. You have definitely inspired, and we want to say thank you for your service.
Thank you.
Thank you.
All right.
All right.
All right, have a good night. This concludes the program.
Thank you.